Hello and welcome back to Friendly Pharmacy 5. Today I have a special friend with me. I have Dr. Fairuz Siraj with me. Now, some of you may recognize Dr. Siraj because he's been on the channel before talking about migraine and he specializes in migraine. But today, Dr. Siraj actually has many hats and he is also a certified diabetes educator. And so today he's going to help me debunk some of the most common myths about diabetes. Dr. Shiraz, thank you so much for joining me today.
Thank you so much, Lindsay, for having me yet again on your amazing channel. And as you said, I do wear many hats. Most of us pharmacists, we wear lots of hats. So today is the diabetes hats, and I'm really, really happy to be here. And I'm hoping to share some of my knowledge and information so that your listeners and audience can improve their diabetes care.
Absolutely. And Dr. Shiraz just got back from vacation and I snagged him for an interview. So thank you for doing that.
My
um,
pleasure, my pleasure. I just hope the audience, excuse my nasally voice. I'm a little bit under the weather, but hey, might make me sound a little bit more knowledgeable.
Absolutely. It will add to the credibility of the
There you
information.
go. There you go.
So, Dr. Shiraz, could you just explain to us, like pharmacists know a lot about diabetes, but there are some pharmacists who are what you are, which is a certified diabetes educator. So, what does that mean exactly?
Yeah, absolutely. That's a really good question. So, for pharmacists, in order to provide diabetes education or diabetes care, you don't have to be a certified diabetes educator. So, this is a certification, an extra thing that we can do to get more credibility. But while you're doing this, trying to get this certification, you do have to meet some criteria to challenge the exam. So one of the criteria is that you have to meet 800 hours of diabetes education. You have to provide 800 hours in Canada. So once you have met that, you do challenge the exam. So once you basically are labeled, let's put it that way, as a somebody who is specializing in diabetes care, and then you can be more noticeable in the community. And yeah, it's more of a specialization, but you don't have to be a diabetes educator to provide education. But those who have a certified diabetes educator, they're a little bit more knowledgeable, they're more specialized. So the way I think about it is that, you have physicians who are GPs, walk-in clinics, and then you have some of the physicians who specialize in dermatology, some specialize in endocrinology. So this is kind of a little bit of a specializations in pharmacist world.
That's a great explanation. Thank you for that. And
Okay.
I know that you have been bouncing around between your community pharmacy practice. You've been in diabetes clinics. You've been doing migraine clinics. But you've shared with me some of the information from your diabetes clinics. And there's actually a lot of diabetes patients out there that are really needing information, which is why we're doing this today. And I know
Mhm.
that you have some slides for us. So we'll
Yes.
do some Q&A after, but you have a quick little presentation that just helps to debunk some of the really common myths out there and helps us to understand diabetes a bit more. So if you're ready, you can go ahead and we will listen intently.
Sounds good. Yeah, no, absolutely. Just like you said, I think diabetes care, there's so much information about it, so much good information, but there's still a lot of myths. There's a lot of misunderstanding about diabetes. So this is a slide deck that I prepared because like you said, I do work in many places. I do work with an endocrinologist as well in her office. So I've created the slide deck to kind of go over some education with patients, and I'm going to be sharing this with your audience today to kind of help everybody set the same, get everybody on the same page. So yeah, hopefully we get to educate a lot of people today. So let's start off with some myth busting. I love doing this because I'll get patients from anywhere, brand new patients with diabetes, brand new patients affected by diabetes to patients who have been having diabetes for a long time. So this is kind of something nice that I usually like to do as myth busting. So one of the common myths that we'll have is diabetes is caused by eating too much sugar. That's not really true. So diabetes can happen because of many factors like environment, genetics, lack of exercise, and poor diet. They all contribute to to leading to diabetes. Another myth that I usually get is people with diabetes can't have any sweets whatsoever. So that's not a true one. I usually get that one from patients who are newly diagnosed, but that's not true. But just like any patients without diabetes, patients affected with diabetes need to follow a balanced diet. And then again, exercise to promote healthy living. Keeping foods like cake and cookies to a small amount is generally a good idea. But that's for everybody. So people affected with diabetes can have their sweets, but always about balance. Another myth that I get is people with diabetes shouldn't eat any fruits. So we know that fruits do have sugar in them, but again, that's not quite true. Fruit usually has less sugar compared to things like cake and cookies and other sweets. Additionally, they do contain essential fibers and other nutrients, so it is a better alternative, but we want to keep it in a balanced quantity. And another myth is that type 2 diabetes is the milder form of diabetes. That's not really true. So, type 2 is not a milder form of diabetes when we're comparing to type 1. I think the myth comes from because patients think that with type 1 diabetes, you're injecting insulin. With type 2 diabetes, you may not be injecting insulin, so it's a milder form, but that's not really true. And I'll go into a little bit about that. So what is diabetes? So what is diabetes? So diabetes is a common chronic disease in which your body either doesn't produce insulin or can't use the insulin properly, which is known as insulin resistance. This leads to elevated blood glucose. And what can happen over time is that you have some common symptoms like increased thirst, increased frequency of urination, changes in weight, so either weight gain or weight loss. You can have extreme fatigue, lack of energy, blurred vision, slow healing. You can even have damage to some nerves that causes tingling and numbness in the hands or feet. So that's kind of what we see when the diabetes is really uncontrolled. And usually when this happens, patients end up in the hospital, and this is where they get diagnosed with diabetes. Usually this is what we see with type 2 diabetes, but it can also happen with type 1 diabetes. So again, another myth is that diabetes is not caused by eating too much sugar, and people can't give themselves diabetes. Like I explained, there are many factors such as background, like genetic background, family history, ethnic background. So for example, I'm South Asian. Both of my parents are South Asian, and they both actually have type 2 diabetes. So for me, my risk of developing diabetes is higher compared to somebody who doesn't have the same background as I do. But there's other factors like diet and exercise and other environmental factors that all play a role. And there's also some medication that can lead to acquiring diabetes, so such as corticosteroids. Now, saying that doesn't mean that if you take corticosteroids, you're gonna have diabetes. It's always about how much you're taking, how long you're taking it, what the doses are. So, for example, if somebody is on a high dose of prednisone for months, and they may be at increased risk of diabetes. So this is where we have to monitor the blood glucose and consider many factors. So we can't just say one thing and have it be as that. So what is type 1? What is the difference between type 1 diabetes and type 2 diabetes? So if you recall from my first slide, I said that diabetes, the general term, is that where you're either not producing enough insulin or you are producing insulin, but you're not using that insulin properly. In type 1 diabetes, what happens is that your own body cell, it's an autoimmune disease where the body immune cells destroys the cells of the pancreas. The pancreas is responsible for making insulin. So when your body destroys the cells in the pancreas, you're no longer able to produce insulin. So this is what happens. I have a little pictures over here. So normally, you will have some meal, you'll have glucose in the bloodstream. Your body will respond by releasing insulin, and the insulin will take in the glucose and put into cells for use such as energy. In type 1 diabetes, you'll have some meals, you'll have glucose in the bloodstream, but you won't be able to produce insulin because your pancreatic cells are totally gone. And you won't be able to take in that glucose. So it's going to be elevated blood glucose in your bloodstream, and that's going to lead to issues. So researchers do believe that genetics and the environment can trigger type 1 diabetes. So how does this compare to type 2 diabetes? Well, first, it's more common than type 1. And again, there's many factors that influence the development of type 2 diabetes. This is where, again, the body either isn't producing enough insulin, or it is producing insulin, but it's not taking in that sugar properly. So here, going back to our little pictures, you eat something and you do release insulin, but your insulin isn't working well enough to bring that sugar back into the cell. So you have elevated blood glucose, and long term, that can lead to complications. So when we're talking about complications, what type of complications can that happen with long-term elevated blood glucose in somebody with type 2 diabetes, for example? Type 1 diabetes as well, but this is something that we usually see more so with type 2 diabetes, because in type 1 diabetes, if you have really elevated blood glucose for a couple of days, you can end up in the hospital with something called diabetic ketoacidosis. In type 2 diabetes is a little bit different. You can have something similar, but we call that hyperosmolar hyperglucose syndrome, HHS to make it short. But long-term uncontrolled diabetes in both type 1 and type 2 can lead to complications like stroke, heart attack, kidney failure, can cause blindness, can cause traumatic limb amputations as well. So those are the things that we want to prevent by controlling our blood glucose, controlling our blood glucose, controlling our blood pressure, controlling our cholesterol as well, and also using specific medications like that'll go into a little bit more, and also smoking cessations and so on and so forth. So what is the big principle of diabetes management? So we focus on diet and exercise as our base. So this is going to be our foundation. So if you're somebody who is type 2, who is affected with type 2 diabetes, we will always start with foundations that way, and then we'll layer on medications. For someone who has been affected with type 1 diabetes, diet and exercise is important. It's also the foundation, but we have to start you on insulin because, again, type 1 diabetes, you are no longer producing any insulin at all, and we have to supplement insulin. So somebody with type 2 diabetes, the base is always diet and exercise. And if with diet and exercise we cannot maintain control of your blood glucose, we have to layer on medications. And there are many different type of medications that I'll get into just in a couple of slides. So when we're talking about diet, this is kind of the picture that you're usually looking at when you want to focus on how to divide up your food on your plate. A really good website to check out is Cart to Table. It has good recipes on how to cook your meals really well and kind of what to look for when you're prepping your meals. And when we're talking about exercise, how much is enough? So usually 150 minutes of moderate to vigorous exercise per week. And you can want to break this down into 5 sessions. And you want to kind of add in some weightlifting exercise as well. So the more muscle you build, the lower, the better insulin will work for you. Let's put it that way. So it's going to reduce that insulin resistance when you build more muscle. So going back to some medications, so there's different medications. many different medications out there for to treat diabetes. So these over here, these oral, there's some oral medications, there's some injectable as well. So these are for patients affected with type 2 diabetes. They work differently to control blood glucose, but not only that, they also help to protect your kidneys and your heart as well. Because most patients with diabetes, they don't die from diabetes, they die from the complications. And some of these medications have been shown to have additional benefits for that. There's also insulin. So this is something that I like to bring up because people affected with diabetes, especially people with type 2 diabetes, if they get started on insulin, they feel that they have failed in some way. They have tried a lot, and they may go to their doctors, and the doctors will say, okay, you know what, it's time to put you on insulin. And it's always a shock. But that's not the case. Look, diabetes, type 1 diabetes, like I said, in that the pancreas is gone and we have to supplement with insulin. And insulin is a life-saving medication. I remember from pharmacy school when we were learning about insulin, the professor would show us pictures of back in the days when there was no insulin. They would show us a child on the left side without insulin. It would look like they had no weight, they were frail, they were practically going to die. And then as soon as you put the child back on insulin, within a couple of months, they're back to looking healthy. So insulin is a life-saving medication. It is effective. Now, with every medication, there is, risks. With insulin, it's a higher risk medication because it can, if you misuse it, it can lead to low blood sugars, which can be detrimental if they're not treated properly. So if you do get started on insulin, it doesn't mean that you have failed. There is one great resource that I'll be sharing with you guys that which is this over here, that kind of explains it's always about risk versus benefits. And insulin, as you progress through your diabetes journey, you may have to be put on insulin. And this little book that we'll share with you guys from our friends at Saskatchewan RX Files, it's available to them for free. That kind of goes over a little bit more why that is. When it comes down to blood glucose monitoring, a lot of patients will tell me, I don't really know what I'm looking for. I don't know how many times to check. So this is a nice little guide. So for most patients affected with diabetes, we want their A1C, which is the 3-month average, to be 7% or less. We want their fasting blood glucose, so that's first thing usually when they wake up, to be between 4 and 7. And their 2-hour blood sugar after eating, we want it to be between 5 and 10. If they have met their A1C target. If they don't have their A1C target, we want that to be a little bit tighter, so 5 to 8. And the reason we do this is because in studies they've shown that being within this parameter does provide benefits. So that's kind of where it comes from. It's again based on Diabetes Canada, which is a great resource, and their clinical practice guidelines. So what are the available blood glucose monitoring systems? So we have many. We still have the older school poking fingers, which compared to what we had before, it is more advanced, so it can definitely be something for patients. But there are also the continuous glucose monitoring, which can really show patients how their blood glucose are affected when they're exercising, how much by what they're eating, what their medications are doing, what's happening while they're sleeping. So it's something that I highly recommend using. And this is something that you can use for a week or as well 2 weeks or so, and you can just get a sense of how things are going. You don't have to use it on a regular basis. If you do use it on a regular basis, it does provide better benefits. And if you want to know if you're poking your fingers and you want to know how often, there's a great tool that you can check out at Diabetes Canada that can kind of go over that as well. Or you can talk to your pharmacist who might be providing diabetes services. So what to do when you have low blood sugars? Well, what is low blood sugar or hypoglycemia? Hypoglycemia happens when the blood sugars are less than 4.0 millimole per liter. We are Canadians, so I'm using that units. But you also have symptoms. Some symptoms of hypoglycemia might be shaking, visions are blurry, increased thirst, confusion. So those are some of the common symptoms that some people can have, and even increased heart rate, sweating. Those are typical symptoms of hypoglycemia. And again, the symptoms do respond to administration of quick carbohydrates. And there's many reasons why low sugars can happen. And one episode doesn't really mean much. It's whenever somebody talks to me about hypoglycemia, I'm always looking for patterns. I'm always looking for patterns when we're talking about blood glucose. So yeah, those are the symptoms of hypoglycemia. And what you want to do if you have that, you want to have quick acting sugars. So 15 grams of glucose in the form of the glucose tablets, 1 tablespoon of honey, for example, or even 2/3 of juice or regular soft drink. And then you want to check your blood sugar in 15 minutes and treat again if you have to. And one of the really important things that I talk to patients with diabetes is during the time if they're sick, what to do. So if you do, there's great resources out there for what to do when you're sick as patients with diabetes. You want to maintain your hydration. You want to try and eat as well as possible. And there's some medications that you might need to stop. Again, in the resource that we will share you kind of goes over a little bit more on that as well. Yeah. So here's some of the resources that we'll be sharing for sure. If you're somebody from Victoria, BC, we have a great place here, the Diabetes Center, that you can do self-referral to. This is the book that I've been talking about. There's the QR code. This is something that called the RX files that our pharmacist friends in Saskatchewan has created. It's great. It's an evidence-based resource. So definitely recommend you checking that out. And if you want more personalized consultations, this is where you can find me. I do consultations virtually as well. I'd be more than happy to help you guys. So there you go. That's my little slideshow. Hopefully it wasn't too long or too boring.
Not at all. That was excellent. Thank you so much. We'll give you a moment to drink some water or something like that.
Absolutely. Thank
You
you.
yeah, so many good points in there, right? And I think that, as a pharmacist, it actually surprised me that there's still such a lack of education or understanding, or even just so much misinformation out there about diabetes. And thinking about, the recent, what I call Ozempic fever, people taking
Mhm.
Ozempic, and, there's just a lot of misinformation. So that was really, really helpful. One thing I wanted to ask you about was, you listed those symptoms that are often common for people who have diabetes, but a lot of people with type 2 diabetes, I think one of the challenges that we face is that often there are no symptoms, and people wonder, why should I be taking this medication? Can't just
Mhm.
diet and lifestyle. And I know that, when you're talking about type 1 diabetes, we see the destruction of the beta cells in the pancreas, right?
Mhm.
And so they just can't produce insulin. But that is not exclusive to type 1 diabetes. We see
Mhm.
that in type 2 as well. So what do you see in your patients as far as challenges in just understanding this, or even taking it seriously? Because it's kind of like blood pressure, right? We don't
Yeah.
necessarily feel that our blood pressure is high. So, you
Exactly.
know, yeah.
Yeah, absolutely. And that's a really good question because so patients with type 1 diabetes, their blood glucose, if there's a little bit of change from a day to day, they will notice it. Whereas with somebody affected with type 2 diabetes, they may not notice it. It's kind of like, do I really need to take this medication? And the way I explain it to patients and get their buy-in is that, again, we're not trying to, you may not notice anything on a short-term basis, couple of days, couple of weeks, or 5 months. If your blood glucose is not controlled, you're not going to really notice anything. It's the long term, it's the issues that happens long term. So like I said, your risk of stroke, your risk of heart attack, having issues with your vision. Those are the things that we're trying to control down the road. So I have this conversation whenever I do provide education for patients newly diagnosed or even long term, and kind of get them to again provide re-education on why we're doing this. Just like I said, blood pressure. You won't notice if you have high blood pressure or low blood pressure unless if it's like in the extremes, right? If you're too low, you will notice that you're dizzy. If it's too high, then you're gonna maybe have some problems and you'll end up in the hospital. So unless you're at those ranges with diabetes, you're not going to really notice anything. And that's where the problems are going to happen down the road. Damages to your kidneys, damages to your retinas, damage to your vessels. And that's what we want to prevent. And we get to this because of all the studies that have been done, really well done and really established. And we see that with patients. I've seen so many patients who we could have prevented, issues, but they either just didn't get the proper education, or whoever they spoke to really didn't go over properly with them. So that's kind of what I always tell patients. And in the little booklet, we do share that we did have a little screenshot, but kind of shares what happens. I'll actually go back to the screenshot. I should have
Sure. Yeah, go
done a
ahead.
little better
No,
job
it's
at
really
presenting
good.
that. Let me go back to that little screenshot over here. So right over here, so it kind of shows, does diabetes medication, so diabetes medications can be life-saving, and the idea that they don't make much of a difference is a big myth. So here they show that on the left-hand side, we have a group of people that did not control their blood sugar, pressure, or cholesterol. And out of those 10 people, 6 people had a heart attack, stroke, or an amputation after 13 years. Whereas on the right side, this is the group of people use the medications and exercise to lower their blood sugar, blood pressure, and cholesterol. And of those, through the risk was cut by half. So only 3 out of the 10 had a heart attack or stroke or amputation. And again, this is where we have that conversation that, look, it's all about risk versus benefit. Just because you're taking a medication, you're not going to have those risks. It's about reducing those risks. That's what you want to do. And that's something that I think, we all need to look at. Just because you're taking something, it doesn't mean that there's not going to be any risk. But if you're taking something, you want to weigh out how much of a benefit that will be. And some of the medications that is out there now has significant benefits, especially for those complications.
Yeah, and that's something I always like to speak to, is that people think that pharmacists, because we are medication experts, we always want people on medications. That's not the case, right? It's always a risk versus benefit conversation. What we want is, we want you to live longer and live a
Mhm.
better quality of life.
Mhm.
And diet and exercise definitely plays into that. And and you said that that's the foundation of
Mhm.
diabetes treatment, right? One of the
Mhm.
things I wanted to ask you about is pre-diabetes. So often we
Mhm.
will see patients with pre-diabetes, and their doctors will usually tell them, listen, you need to lose weight, you need to get your A1C down. But I feel like, just saying that is not really the most helpful. There are a lot of opportunities, or missed opportunities, I think,
Yeah.
for people. What do you see in your practice? Like, what do you think are some of the biggest missed opportunities? Even having people use a blood glucose monitor, or, a CGM earlier on, could be really helpful. What are your thoughts on this?
Yeah, absolutely. That's a really good thing. So, during my consultations, I also use a point of care testing that checks the A1C. So I offer this, patients love it, but I also give them the CGM, the Freestyle Libre, as well, so that they can kind of see how things are changing, and they make changes to their habits. So they will incorporate exercise. They will visually see what happens to their blood glucose when they're eating certain foods or a certain amount of foods. And I think it's about changing habits. And when you incorporate that, you can actually make a significant difference. I think using one of those CGMs alone can have even a better effect than taking medication, some of the medications. So, and it's a non-medication therapy, right? So I highly recommend, talking to a diabetes educator, trying on one of those continuous glucose monitoring, and getting good education about what changes you need to make if you're somebody who is pre-diabetic or even have high risk of diabetes. So like myself, for example, I know I have a sweet tooth for sure, but I do, whenever I wear my CGMs, on occasion I do that. Um, it reminds me that, okay, look, this is what's happening when you're eating this much or this amount or this type of food, or this is how your blood glucose is well controlled when you're exercising on a regular basis. So those are really nice things to use because we have the tools now to visually get a response of what's going on, and it can have a huge difference in somebody who is prediabetes or high risk of diabetes.
Yeah, exactly. And when patients are using these CGMs, often they're
Sure.
seeing
Yeah.
spikes in their blood glucose, right? So
Mm.
you eat like a dessert or something like that, and you'll see a spike, and then, sometimes it'll drop. You say if you're pre-diabetic or something like that, it'll drop rather quickly. What does the research tell us, or have you read anything about how these spikes affect us long term? Because we always refer to the A1C, which is the average blood glucose over about 2 to 3 months, right? But when we're seeing
Mhm.
these spikes, are those also adversely having an impact on the body?
So let's talk about somebody without any diabetes or pre-diabetes, anything like that. You will, if you're having something that has, let's say if you have something really sugary and in a liquid form, like apple juice or orange juice, you will get a high rise in your blood glucose. You should, because you're
Yeah.
ingesting it really fast and it's gonna go really high. It may come down quite quickly as well, which means your body is responding well to the glucose. So and we're doing this without thinking. So our body is so calibrated well to notice how much glucose is going in and responding well with insulin to take that in to control it well. Um, let's say comparing to that, if you have something, let's say that has less glucose and it's more starchy and you're having it with some cheese and lots more fats, so the digestion takes a little bit longer and your blood glucose may not rise as fast. So I don't really know about the long-term effects of having multiple spikes. What I do know is that if you're always having high glucose, this is where your body is going to again try to calibrate by making causing insulin resistance. Basically, it's where your body in type 2 diabetes will make that insulin not as effective because it's always going to be releasing insulin to try and grab that. But again, it doesn't happen for everybody. You have that genetic predisposition. So for example, if for myself, if I'm not controlling how much I'm eating and adding exercise, and I continue to do this for months on end, I'm going to put myself at risk of getting insulin resistance. There's an insulin resistance. It's not just that one part. It has so many factors. For example, abdominal obesity is linked with insulin resistance. So there's many. It's a complex scenario, but all of those factors just play into that. I hope that answers the question.
Yeah, that's great. And then just one last question. I have actually a viewer just posted a question on the channel
Yeah.
today, and it actually is a lot of people have asked similar questions on the channel. And we did a video recently on morning blood glucose. Why are my sugars so high in the morning? And, what do you say generally? And I know this, like you just said, this is a more complex
Mhm.
answer probably, right? And
Yeah.
it's very individual. But what do you say to the patient who is just saying, I'm trying everything. I'm exercising, I'm
Mhm.
watching what I eat, and every single morning, my sugars are high. What are maybe just some starting points
Mhm.
for people to kind of like do some detective work to try to figure out what exactly is going on?
Yeah, absolutely. So, okay. Again, going back to our subject, without any diabetes, without any risks. So we all will have those, everybody will have a spike in their morning glucose. That's a normal phenomenon. This is where cortisol gets released, and it's something that will always happen. The issue becomes, when we say high blood glucose in the morning, what is exactly high for you? As for somebody with diabetes, again, for my slide, we want your fasting blood glucose to be between 4 and 7. So for somebody with diabetes, affected with diabetes, if you're out of range, so if you're higher than 7, say like 9 or 10, and it's a continuous pattern, so if you do notice that it's happening almost every single day, that's when we want to talk about, are you taking your medications properly? What are you eating the night before? Are you exercising on a regular basis? So if you're meeting all of those, so if you are taking your medications properly, if you are exercising, if you're controlling what you're eating the night before, and you're not going out, getting up and having some snacks, like sweet cake, sweet things like cake or cookies or anything like that. And we do calibrate those, this is where we want to ask, okay, how far are we along in your diabetes journey? Because diabetes is a chronic disease, and it's the way you want to think about it is aging process. Your pancreatic cell, as you mentioned, does deplete, and you're not producing insulin properly. Somebody without any diabetes, we produce two types of insulin. We produce the background or basal insulin that takes care of morning glucose, takes care of background glucose as well. And then we also have another type of insulin that we release, which is after meals. So with somebody with type 2 diabetes, affected with type 2 diabetes, I should say, the morning insulin that we release might get depleted. So this is where you're not covering that morning rise in that cortisol release that happens. And this is where we have to think about, starting insulin. And again, if we do go into that route, it doesn't mean that you have failed. It's just the natural progression of diabetes that can happen, natural progression of aging that can happen with anybody. The other thing that I should have brought up is that a factor in leading to type 2 diabetes is age. As we get older, our body starts to break down, and it is a risk factor of having diabetes. So for the individual who put in the question, thank you. That's a great question. And others who have similar questions about fasting blood glucose rising. So if you've looked into the patterns, if it's always high, if you have always looked into exercising as normal for you, like you're consistent, you're eating consistently, you're taking your medications consistently, I think it's time to talk to your healthcare professional and see exactly what's going on. Adding a CGM to find out what's happening would be helpful as well, and then we can have that discussion about, do we need to make changes to your therapy or so on.
Yeah, that's an excellent answer. Thank you for that. Also, if you are listening to this interview and you do use a CGM, let us know in the comments what CGM you're using and maybe what questions or challenges you're having with your CGM, because we do want to cover that on the channel, and that's just part of a lot of the diabetes education that we'll be doing on this channel. So thank you so much, Dr. Shiraz, for taking some time today after your vacation, even with a cold. That was
My
just some
pleasure.
incredible information you shared with us. We'll have you on again because you're always such a wealth of information. You always bring little tidbits that I don't even expect, right? And I always learn something from you as well. So thank you for this. And go to that resource that Dr. Shiraz told you guys about, the RX files. It's a free booklet. It's really well laid out, really easy to understand. And then also, if you want more information, we'll leave the contact information for Dr. Shiraz in the description of this video as well. So you can always reach out to him if you want like a personalized consultation or something like that. Dr. Shiraz, thank you so much for coming on the channel again. It's always a pleasure to have you here.
My pleasure. Thank you again. This was awesome. I love chatting about disease management, and I love being here. So thank you again. And yeah, if there's questions, I'm more than happy to, answer them. So contact me.
Absolutely. Thank you
All right.
so much. Take care.